Okay. Hi, everybody. My name is Tate. Um, Today I'm going to talk to you about cardiac vascular anatomy and physiology through a case-based approach. That's going to be really basic, so we're going to basically do it at a crash course pace. So I'm originally from Marble Hill. You probably all know where that is. I graduated in 2019, so I'm not that much older than you. I'm 24 in 2019 from Meadow Heights in Patton. For undergrad, I attended Central Methodist University. I majored in chemistry. I took a lot of biology classes and things like that too, because in order to get into med school, you have to meet certain requirements. So I took those classes. I'm also part of the 3-4 partner program in osteopathic medicine. So basically, I spent 3 years in undergrad in Fayette, Missouri at Central Methodist, and then my first year of medical school counted as my fourth year of undergrad. And now I'm in my third year of med school at Kansas City University College of Osteopathic Medicine in Joplin, Missouri. There's a second campus in Kansas City, although I guess we're the second in Joplin, but I like not to think of myself like that. So basically, for med school in years 1 and 2, you spend a lot of time in the classroom learning. They call it didactic, like lecture-based education. But now I'm in my third year, of course, so I'm out in clinics and hospitals. I'm currently at Mercy Southeast in the NICU. Next month I'll be with OB in Poplar Bluff. And then after that, I go into residency training. So I was just asked to kind of give a basic overview of what my schooling has been like, my medical school journey. Does anybody have any questions on that before we kind of dive into the cardiac information? Okay. So I just wanted to give a basic overview of like coronary vasculature, because at the end, we're going to have some cases to go through. I brought some cases. We'll split up into groups and kind of go through things. But if you're not familiar, essentially, you can think of coronary arteries as the vessels that surround the heart, the vessels that supply the blood to that heart musculature so that it can adequately get oxygen to be able to do its job, to be able to pump effectively. If we're not getting blood there, that muscle is not going to get perfused with that oxygen and it can't pump. It would eventually die. So there are a few important structures to think about. So we have our right coronary artery right here. So the red structures is all we're going to focus on right now. Those are the arteries, and the blue ones, those are the veins. We have our right coronary artery coming down and feeding to the lower portion of the part, and we call the lower portion inferior, whereas top would be superior. So like my head is superior to my feet, whereas my feet are superior to my head, inferior to my head, sorry. Here we have the left coronary artery coming to the left side of the heart. If you were to think of it like this is my left side, so this is the left side of the heart, and it gives off a very important branch. That's called the the left anterior descending artery, and we'll focus on that later whenever we think about some EKG changes and what can happen whenever structures like that go wrong. And we also have another important structure here coming off of the left coronary artery, just like that left anterior descending. This is the left circumflex artery. So those are just some general front structures of the heart, anterior. And this is a picture of a real heart, like as it was taken out of a cadaver who donated their body to science. So we can see again this right coronary artery and this kind of segmental branch going down to the point of the heart. We call the point the apex of the heart. So remember again, this supplies the right side of the heart and the inferior portion, the lower portion. Here we have our left anterior descending coming off of our left coronary, and we would have our circumflex branch going off to the side here. And I'm pointing out these directions because that'll be very important whenever we think about our EKG changes. That's mainly what we're going to look at today, like how those EKG changes and things like that reflect what's happening with the heart as opposed to the anatomy itself. And then on the back side of the heart, we can see that this right coronary artery was wrapping around to the back. So here we have that right coronary artery, and we have it kind of diving into that muscle tissue and then popping out again right there. That would be the posterior interventricular artery. So just think of the right coronary feeding not only the inferior and right portion of the heart, but also the backside. And then also an important element of cardiac physiology to take into account is how the heart is actually able to pump to begin with. So if we think about our heart, it actually has these electrical locations inside of it that are able to conduct very small amounts of electricity in order to make that heart squeeze. Like if you've ever seen like a TENS unit or something like that, where like a therapist might put on you to contract those muscles, whenever you do that, that muscle tightens up. Well, that's exactly how this works, except we're talking like microvolts, like tiny. So your heart actually does generate electricity, and it does that to be able to cause that muscle to squeeze and be able to pump that blood from one place in the heart to another and then eventually out to your body. So if we think about that electrical conduction system, it all starts at something called the SA node. And that is in the atria of the heart, specifically on the right side. And that SA node, that electrical impulse, initiates right there. So whenever it starts at the SA node, that electrical signal says, okay, we're starting, we're going to go down to the next spot. That next spot is the AV node. And as that happens, you can think of that whole atrium, like that top chamber of the heart, because we have our atria on top and then our ventricles. We have our two upper chambers and then our two lower chambers. After that SA node and AV node contract, along with some various little branches that kind of go throughout, but these are the main points. After those contract, that atria is going to squeeze because that electrical impulse has already gone through them. But in order for that blood to get to lower portions of the heart and eventually out to the body, it's important for our lower chambers, the ventricles, to also squeeze. So how do we get down there? It's through something called the AV bundle, or you might also, if you've heard of it, the bundle of His. So after we go through the SA node and AV node, we travel down to the AV bundle, and then in order to get to separate sides of the heart, the left and right ventricles, we pass through the right and left bundle branches, and then out to something called the Purkinje fibers. So by that happening, we're able to start at the top of the heart. We get those atria to squeeze just like they should, and they push that blood down in the ventricles, and then those ventricles squeeze and push it out, in this case, either to the lung on the right side of the heart, or on the left side, out this big structure here called the aorta and out to the body. So we start at the atria, it contracts, squeeze nicely, and then the ventricles, they contract and then push out where they're supposed to go. So with that in mind, we can then think about how an EKG is generated. So you've maybe seen an EKG or know somebody who's had one done, where they place all the little stickers over your body. And basically what that's doing is measuring that little microvolt amount of electricity that's being generated by the heart. So based on where those leads are placed, we're actually able to measure different parts of the heart's electrical conduction. So remember how I said that the conduction starts at the SA node and then eventually travels down after it goes through the atria to the ventricles? That's what it's showing here. So we start at atria, go down to the ventricles, and then ultimately those pieces also relax. So whenever the atria, the top chambers of the heart, contract, we get a small bump on our EKG, an electrical signal, and that's known as the P wave. So whenever the atria contract, whenever that electrical signal gets there, it's known as depolarization. That's like a whole topic in and of itself, but essentially just know it's known as depolarization of those muscle fibers. It causes them to contract, and we get this upward little bump known as the P wave. And after it travels through the SA node, AV bundle, down into those ventricles, the ventricles are going to contract, and on our EKG, we get this change here. It's known as the QRS complex. And each little component is a different element, but just know collectively that the QRS reflects the ventricles contracting. And then our last bump, in order for those ventricles to be able to contract again, we don't just atria contract, ventricles contract, because you would have one great heartbeat in your life, then you'd be done for. So we want them to relax so we can do it all over again. So this T wave is actually whenever the ventricles, whenever they relax, whenever they go back into a position to be able to accept more blood again. That's known as diastole. And you might wonder, well, what about the atria? Don't they have to relax too? They do. That's a good point. But because of this huge QRS complex, the atria relaxing or repolarizing is actually covered up by that. So we have our P wave, atria contracting, QRS, ventricles contracting, and then ultimately our T wave repolarizing and relaxing those ventricles. So that'll be important to remember. So this is a picture of what a real EKG looks like. So we can see that we have various numbers and letters up here, and those are each attributed to different locations. Let me see if I have a better picture of that. No. So each of those numbers and those letters correspond to individual stickers placed on the body. And there are more stickers than what's pictured right there. But think of it as 1 from here to here, that's a sticker. AVR, that's a sticker, and so on. And like AVF, that's a sticker. V3, that's a sticker. So it gives you an instance of like all of these electrical changes, being able to see them in a whole bunch of places. And then this bottom row, that's known as the rhythm strip. That's essentially just a long, drawn-out version of one of those leads, usually lead 2, just so you can see those electrical changes over a long period of time, but not have just pages and pages of each individual lead. And we'll go more into that. So those leads that are placed, all those little stickers, in order to understand what's happening in the heart electrically, you can think of all those little stickers as essentially little cameras. So if I place a sticker up here on my right side, it's essentially taking a picture, a snapshot in time of that electrical activity from the right side of my heart. But if I place a sticker over here, it says, okay, I'm not worried about the right side. That sticker is going to look at the left side of the heart. So if we think about the heart in general, remember how we had different vessels being affected on different sides? Well, if that portion of the heart electricity isn't going like it's supposed to, it could indicate that, well, maybe we have poor blood flow, maybe there's a blockage, a whole plethora of things. So if we have those specific leads on the body to indicate that electrical activity, it can give us a lot of great information. So there are some various leads to think about. We have one called AVR. That one gives information about the right side of the heart, so the R. The AVL, that gives us information about the left side. 1, that's also the left side. 2, that one is kind of left, but specifically around the apex, the point of the heart. AVF, so F, think foot, so like inferior portion of the heart. And 3. And then we've also got these leads. V1, 2, 3, 4, 5, and 6. Those are known as precordial leads. It just has to do with where they're placed. So instead of being placed like on the feeder, for example, they'll actually be these specific leads right here. These are the precordial leads. And those give more specific information about the frontal plane of the heart, like anterior. Because it's important for us to think about the right, left, and inferior portions, but like, what about those arteries in the front? What about the electrical activity on the front of the heart? Well, that's what these V leads are for. So 2, 3, and 4, those specifically kind of point directly at the interior, the front portion of the heart, whereas V2 gives us information about the front, but also leans a little bit toward the right. So it's a little bit more information about the right side in addition to AVR. And V5 and 6 tell us somewhat about the front, but also more on the left. So just think about those leads as just individual cameras pointing at the heart in its electric activity. So now, if we think of about those things specifically, we've talked about where those leads point and what activity they analyze. So for example, if we think about leads 2, 3, and AVF, those are more for the inferior portion of the heart. So we can consider those arteries that would be affecting there. And 1 AVL, we know that those were on this side of the heart, on the left side. So based on the left side, we can think about which arteries would be affected. So we could think about, well, is it the LAD? Is it the circumflex? And AVR and V1, those are going to be those leads that are taking pictures specifically of the right-sided electrical activity. And then 2, 3, and 4, just like we mentioned previously. So leads 2, 3, and 4, those stickers placed right there, that's about the front plane of the heart, or anterior. The front of the heart would be anterior. So that would be specific information in this region right here. So those vessels corresponding to the front of the heart, that's where that LAD, like we talked about earlier, that left anterior descending coming off the left coronary artery. If we saw some sort of issue in the electrical signal in 2, 3, or 4, we could think, well, what vessel is in that area? So we could begin to be concerned with what's happening within that left anterior descending artery. And then likewise, in 5 and 6, those also correspond with 1 and AVL. I'm thinking about that left-sided heart electrical activity. And this is just another picture that breaks it down specifically into, well, this picture here explains the vessels, but it doesn't necessarily list them for each one. But this gives a great description of which vessels are affected in each of those leads. So if we think about the inferior portion of the heart, it represents the red, so 2, 3, and AVF leads. So that would be the right coronary artery. If we go back to our picture here at the beginning, remember that right coronary artery, how I said to remember this segmental artery coming down, goes to the inferior portion of the heart, the apex, and how the left coronary artery correspond to 1 AVL and 5 and 6, because that would be the front of the heart. So we have that left coronary artery, our LAD, coming down. So that's what it's describing there. And then also our lateral leads. Lateral meaning the side portion, or in this case, you can think of it as left, because on the left side of the heart, we have our circumflex artery branching off the left coronary artery. So just like the LAD, except we have our circumflex, and it feeds this left side of the heart, the lateral portion. So with all of that in mind, it's important to think about what happens whenever those arteries are blocked. And whenever that happens, we get a myocardial infarction. Does anybody know what the more common term for that is? For myocardial infarction? It's a heart attack. So whenever we have a heart attack, the doctors in the background are saying, well, here's a myocardial infarction. They're sounding all smart, but they should just say heart attack. It seems like, no, not really. But based on that information, wherever that is occurring, wherever those heart attack symptoms are occurring, which we'll talk about, we can think about, well, which vessel is actually affected. Because in a myocardial infarction, in a heart attack, essentially you have your blood vessel in that area. For this example, our LAD, a piece of cholesterol or fat has built up over time, causing inflammation in that vessel and causing it to get blocked off. Well, if it gets blocked off, is blood getting to that portion of the heart where it needs to be? No, it's not. And if that heart muscle cannot get oxygenated, it's not going to contract properly. So whenever that happens, we get specific changes in our EKG that indicate what may be happening, in addition to some other labs and stuff you do, but we're not going to talk about those. But essentially, in a myocardial infarction, we get a specific change in our EKG, and that's known as ST elevation. So if we go back, I don't think I have the slides I went before. So if we think about our EKG parts, like we had earlier, we have our P, QRS, and T. We can see that from various points, we can measure distances based on where they're occurring. So from the middle of our P wave to the beginning of our QRS complex, this is known as like the PR segment, because it's going to from the P to the R. But from the end of our QRS, from the end of that ventricular contraction, from where the heart is pumping, to the beginning of the relaxation of that ventricle, we have something known as the ST segment. And there's other various elements, but we're specifically going to think about the ST segment. So in that portion of the EKG, whenever you have a heart attack or myocardial infarction, instead of that EKG being nice and crisp where it just does atrial contraction, QRS, T wave, instead our QRS is just all out of whack. And you can see that our S portion that should be down here, it's now really high and elevated. It's also kind of described as like a tombstone appearance, and that's kind of ominous because we know how many people unfortunately pass away from heart attacks. So we get this ST segment elevation. So this is an example of a portion of an EKG. And then we can see while this lead looks pretty normal, we have our P wave, our QRS, our T wave's kind of hard to see. But in this V2 lead and V3, we can see that this is not normal. We have like this tombstone appearance, and that would be ST segment elevation. So this person would certainly be of concern if they were presenting with heart attack-like symptoms. We'd want to get them treated right away. So if we look at this bigger EKG right here, it's important for us to, first of all, figure out what we're looking at. So we see we have all of our leads. We can see we have our rhythm strip at the bottom. And whenever we think about this, then we can begin to analyze, well, which leads are affected. In this case, I'll just tell you we're worried about a heart attack. So does anybody see any specific leads that like would show that ST segment elevation? You can just name one out or two. There's actually 3 of them. You have a pretty good odds of getting one. AVF, good. Does anybody see another one? 3, good. And one more? 2. So we can also see that AVL and V2, those look like they have some kind of weird similar thing going on. But whenever they're upside down, it's known as something called reciprocal changes. Those aren't of themselves called ST elevation. So whenever they're upside down, that it's still concerning, but it isn't specifically what you're looking for. So you want to look for the ones that are right side up. So we see that we have ST elevation in 2, 3, and AVF. So if we go back to our slide earlier, in our EKG, we're having concerns 2, 3, and AVF. So we're worried about the inferior portion of the heart. So what would be affected? The right coronary artery or possibly the circumflex. We're not going to worry about that though. We're just going to go with the right coronary. And that is because in our heart anatomy, our inferior portion of the heart is fed with blood from that right coronary artery. So that person with that EKG very likely has a blockage somewhere in this artery. It could be, it could be here, it could be there, it's hard to say, but they have got something called atherosclerosis. That artery has gotten inflamed and it's gotten blocked off, and that heart tissue is actively dying in them, so they need to be treated right away. And you'll have the opportunity to look at more of these ST changes later. This is another example of those ST elevations. Does anybody see any changes in this EKG? Any ST segment elevations? AVL, good. Another one? 1. Are there any more? Doesn't look like it. The other ones are just upside down, so reciprocal. So if we go back to our picture, 1 and AVL, and you'll notice that it says V5 and 6. However, those don't really exhibit those changes, and they don't have to. There may only be a portion of the leads affected. So 1 and AVL, those are our affected leads. So which one is it? It's likely our left coronary artery of our LAD. So on our heart anatomy, this man or woman, whomever it is having these symptoms, they likely have a blockage in their heart in our left anterior descending artery. And that artery is also called, kind of a spooky name, the Widowmaker, because of how many heart attacks actually occur based in that vessel and how many people they sadly kill. So we can see here an image. These are known as angiograms. So in order to diagnose these issues in those arteries after we get the suspicious EKG, they actually go in with a little needle and a catheter, either in your groin or your arm, and they'll inject it in there, and they can put dye in those vessels, and under x-ray, a movable x-ray that's actually not just a still image, but it's like things are moving, like when you stick your hand under this thing, you can see like your skeleton. But after you put that dye in there, it fills those vessels, and wherever that dye goes, it should make that vessel completely dark wherever it's open. But we can see right here where the arrow's pointing that dye is not getting to this portion of the vessel like it should. And that's likely due to that plaque buildup, that atherosclerosis in that region. And this would actually be, it looks like, of our right coronary artery. It says our right anterior oblique. That's a more nuanced structure. But of that structure, we can see that we have atherosclerosis, so they are actively probably having chest pain in that region, need to be have that vessel recannulized and open back up as soon as possible. And then this structure, we can also see a similar image. We can see some narrowing of this vessel here and then up here, so it's not as open or patent as it should be, and that's likely causing significant issue to their heart muscles and actively causing those muscles to die. Yeah, it looks like they had. Yeah, so whenever if in a case where you're not able to just stick a stent in and reopen those, you may have to take a vessel out of your leg or sometimes in your chest, and they'll cut your chest open and they'll essentially do a graft of a vessel in that region to be able to recannulize and supply blood supply back to that muscle. But before you just go to open heart surgery, typically we do something called percutaneous coronary intervention, and that's just stenting. So just like how they stick the needle in and put the dye, they can actually stick a small wire in, and it has this balloon wrapped around it, and then around that balloon there's this little small mesh cage, and whenever you inflate that balloon, it just pushes it open, and then it won't close back down after you inflate it, and that's a stent they're putting back in there. So wherever you have that narrowed region of the artery, like in this vessel here, we had some narrowing, but whenever they stuck that balloon and metal cage in, it pushes that vessel back open, and it's no longer compromised there, so that blood can adequately get to that heart muscle. But then if that doesn't work, you can, or if it's serious enough with enough vessels affected, they'll do something called a CABG, coronary angio bypass graft. So aside from heart attacks, we're going to think about another pathology of the heart, another issue that'll come up in our little cases we'll do. It's known as atrial fibrillation. You've maybe heard its short name, AFib. So in AFib, whenever we talked about our electrical conduction of our heart, instead of that electrical activity occurring at the SA node and then going to AV and down our branches and bundles, respectively, instead of that happening in that beautiful order that it's supposed to, and instead of it all happening, like beginning at the SA node, it says, we're not going to do that. We're not going to worry about our starting spot. We're going to start here, 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 here. So it's like, instead of all of these workers just going in order, it says, no, I'm going to be boss, I'm going to be boss, I'm going to be boss, I'm going to be boss. So we have all these weird starting points, and those are known as foci, electrical foci, so just a little random starting points. So we're not starting here, we have all these new starting points. And whenever that happens, instead of getting a nice strong atrial contraction, instead of it pumping like it should, it says, we're going to start here, here, and they're also not starting at the same time. I mean, you would think that more impulses would be stronger force, like we get more blood out, great. No, they don't start at the same time. That's why it causes the issues. So instead of the atria contracting, they fibrillate. And fibrillate, you can think of it just kind of vibrating. So those electrical impulses don't allow that blood to be pumped effectively down to the ventricles. And whenever that happens, that blood can be allowed to pool, pool being like linger in the atria and not be pumped down like it should. So whenever we have AFib, instead of our nice EKG and its changes like we should have, PQRST, we can see that we don't have the same thing here. And we try to think about what's different. Well, we know that something should be happening with the atria. So remember that our P wave, those represent our atria contracting. And we can see here that if we look, I mean, we have some little bumps in our electrical activity, but I mean, it's hard to say what it is. So we don't have any discernible P waves in this EKG here. And that's because those P waves are not being generated at the same time. And also, we'll notice that instead of QRS, 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 we'll get QRS, 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 QRS. So it's not, the heart is not pumping at a normal pace. It might go pump, 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 pump. So it's not beating like it should. And then based on those changes, we can begin to think about, well, maybe they have AFib going on. This picture kind of just shows a more complicated version of this one. I don't remember why I even put that on there. I think I thought it was nice, but I don't really like it that much now. But just remember that we're looking for our P wave, and then in AFib, we don't have those discernible P waves, and we have that irregular rhythm going on. So this is a bigger EKG of a patient with AFib. So we can see that if we look at our big long rhythm strip down here, we have our QRSs, but who knows where our P waves are? I mean, it looks like we have a tiny one there, but there might be one there, but it's all mixed up with all that mess. And here, it's who knows where it is. They're very, very indiscernible. Like, what's happening here? Are we having like 4 of them? Who knows? And our QRSs, instead of just being nice contractions, we can see that what happened here? The heart, it just like took a vacation. It's not beating like it should. So instead of having those strong beats, we're not only lacking our P waves, but our heart in general is not contracting like it should. So those are the changes you'll see with AFib. So we talked about previously with AFib that blood not pumping as it should through the atria and down in the ventricles. But whenever that happens, that blood sort of swirls and begins to pool in that region. Well, what do you think would happen if that blood is not getting pumped out like it should? Have you ever had a cut, and whenever that blood bleeds out of you, it's not like you just constantly keep bleeding. That blood's going to clot. If blood stays in the same area, it'll eventually clot. And that can cause big, big problems because we don't want clotted blood running through our body. And specifically, in this portion of the heart, known as the left atrial appendage, blood clots as it's sort of like a little alcove, like a little lobby of the heart. Blood clots can form in there and just collect and then ultimately cause issues. So whenever we have a clot in our atria, so if we say this person has AFib and they have blood pooling on either side of their heart, in this case it would have to be on the left side. But if in our left atrial appendage they have AFib, we have a blood clot pooling, it's able at any time to slip out of that atrial appendage and just be pumped out to the rest of the body. You might think, well, that's a good thing. It's not in our heart anymore. No, that's a really bad thing. Because as it passes through those vessels, depending on where it goes, it can be detrimental. But if it passes up through the carotid arteries, going to our brain, ultimately that clot gets to a point that it just gets stuck. Because that clot, it's not like it gets smaller as it goes. I mean, it might break off and create even more debris. But as it gets down to those very small vessels, that blood clot is going to get stuck in those small vessels of the brain. And whenever that happens, the brain tissue, just like the heart in a heart attack, is no longer getting blood supply, getting oxygen like it should. So we get something called a stroke. This is a picture. It's a CT image of a patient's brain. And we can see here, this looks, I'll just tell you, fairly normal. But in this portion of the patient's brain right here, these are ventricles, those are normal. But we have this very black structure. So we can see that the brain there, the patient's actively having a stroke. It's embolic because they likely have a blood clot going to the vessels in their brain, and that brain tissue is actively dying. So when you want to be able to look for those changes and look for the symmetry of the brain to see what looks different from the right from the left. And then we can see that on this side, there's significant issues there. And then another concern, if it's on the other side of the heart, so we were previously talking about in the left side going through the carotids, but if it's on the right side of the heart, and we didn't go through specific blood flow of the heart, but just know that the right side of the heart, after it goes through the atrium into the ventricles, it ultimately goes out to the lungs so that blood can get reoxygenated so it can get reperfused, so you get blood in your tissues. But anyhow, as that goes out to the lungs to pick up more oxygen, that just like in the brain, how those vessels get smaller and smaller, that blood clot can again get hung in those arteries and cause something called a pulmonary embolism. So a blood clot is also known as an emboli. So whenever it gets stuck in those areas, the lung itself is no longer getting, excuse me, my mouth's getting dry, is no longer getting blood like it should, and those arteries are not going to be able to perfuse oxygen back into the cells like it should. So here we have a CT image of the chest. This image is if you were to take a cut of me this way, and this one is if you were to cut me this way. So this is transverse, and this is frontal or coronal. And these white markings here, this is the spine, here are the ribs, here are more ribs, here's the spine. But these white structures here, what we're going to focus on, that would be contrast, just like whenever we did an angiogram. Whenever we put contrast in there, all of that white material should represent where that contrast is going. And ideally, you would want the whole vessel to be lit up, because that would mean that the vessel is completely open, there's nothing inside of it. We can see that as this vessel bifurcates or splits in two right here, that we have this sort of black-like appearing structure in there, and that's actually a blood clot blocking blood flow to this patient's lung. And the same thing here, as it branches off, we have this huge blood clot right there. I mean, that thing's probably this big, branching into this patient's lung. So they have some serious issues, and they would have significant chest pain happening because they're not getting adequate blood flow to that area, and they would need to be treated right away to prevent death. So if we think about a pulmonary embolism specifically, you've maybe seen vital monitors at a patient's bed. So normally, this is what a monitor should look like. We should have a heart rate of less than 100. So 60, for example, that's less than 100. That's pretty good. And we can see that we have our nice P wave, QRS, T, and our SpO2. That represents our oxygen availability. Ideally, you want that to be at 100%. And then our blood pressure, a normal blood pressure would be 120/80. This bottom one we're not going to worry about. But in a pulmonary embolism, for example, our heart rate is going to be over 100, because if we go back, even though that blood supply is blocked off, our heart says, okay, well, we're not getting enough blood there, so let's just pump harder. Our heart says, let's just pump harder in order to get that blood supply there. But whenever that happens, it's still not going to work because there's a block. So we're not getting adequate oxygenation in our tissues. And likewise, we'll also see a drop in our blood pressure. So 83/43, that would be a very concerning blood pressure. They would probably be in the ICU. So you might wonder, well, how do we treat AFib if it's so bad? So typically they'll start with drugs that modify the rhythm of the heart to try to get that to even out, something called amiodarone or various things like that. We're not going to talk about pharmacology though, but we'll talk about two procedures. And one specific procedure they can do is something called cardiac ablation. So just like we've talked 2 or 3 times now about sticking a little needle into the arm to take an image, we can stick this little probe-like structure in there and actually feed it inside the heart. And then on the end of it, it has a little electrode. So a little tip that's able to create electricity, and electricity is essentially heat. So we can take it to those areas that are creating those just random starting points. So we want our starting point to be here at our SA node, but instead our starting points, they're all over the place. So we can take this little electrode and say, it looks like a starting point is right there. And we're just going to, and in order to get rid of it, you just burn it. So if you burn that point, it'll no longer create that electrical impulse. So whenever they do that, they're able to create like 3D mapping. I think this is really neat, because this is like from the outside looking in, but around, those starting points are actually around pulmonary vessels in the heart, but all of these little red dots indicate all the burn points that the electrophysiologist or physician took during that ablation to prevent those abnormal points of electrical activity. And another procedure they can do is called the Watchman device implantation or Watchman procedure. But essentially, they once again send that little catheter inside the body. If you haven't noticed, cardiologists love catheters. But they send that little catheter inside of the left atrium. And where we mentioned that that left atrial appendage can collect those clots, we can stick this little device in there to essentially block off that appendage to not allow those clots to collect there. So that just gives an example of two procedures that can be done in AFib to, one, stop those electrical impulses from happening, and two, with the Watchman to prevent any bad clots from forming. So we are going to go through one case, and then I have 3 different cases that we'll split up into groups for. So here we have a 58-year-old male. His name is Artie Occlusion. I tried to make it fun for you. So number 1, it's asking to identify the patient's primary issue. So can anybody point out, based on this EKG, what this patient's likely suffering from? A heart attack. Good. How do you know that? What are you looking for? Yep. So we have tombstoning based on our ST elevation. Where do you see those little tombstones appearing? 2, 3, and AVF. Very good. So based on that, we know that those leads placements go back to specific vessels in the heart. So based on 2, 3, and AVF, which coronary vessel is most likely affected? Right. Yep. So right coronary artery. So if we go back to this picture, once again, our inferior portion corresponds to 2, 3, and AVF. So our right coronary artery supplies that region. So we likely have a blockage there, also depicted in here. So we have 2, 3, and AVF, inferior right coronary artery being affected. So now I have 3 more cases based on the stuff we've talked about. So how many students do we have? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 18. So we can split into